Good morning. I'm Dr. Dan Lieberman with Best Practice Live. Great to see you today. I'm really looking forward to sharing with you a very common dilemma. Our caller is a young man, former Marine, injured himself in the service, and now has significant residual back pain as our national thank you for his excellent service. It's facet pain versus annular tear. We've seen this movie before, and I'm really excited to show you how it ends today on Best Practice Live. Tell me, John, what's going on with your back?
Um,
Josh.
I got injured about 6 years ago, 7 years ago. I fell off a cliff during a routine patrol on a deployment, and ever since then, I've just been in pain.
You look like a Marine. Is that was it? Yeah, okay.
Yeah,
Yeah. All right. So, and I'm sorry, that was 6 years ago. How far was the fall? About how many feet?
about 20 to 30 feet.
Oh, so good fall.
Yeah,
20 feet is 2 stories, and the LD50, the height at which half the people die from falling, is 20 feet. So it could have been worse, but I'm
yeah,
glad you're
could have been
here.
worse.
And did they know you were on active duty at that time? So I'm assuming they sort of did nothing.
Yeah, basically.
Right. MRE.
Band-Aid fixes.
Yeah, yeah. 800 milligrams of ibuprofen and back to it, right?
Yep,
Yeah,
basically.
yeah. The Ranger candy. Okay, so you went back to it, but it hurt. Tell me, back then compared to now, when the pain first started, was it all in the back, or was it into the back and the legs, or where was it?
It was mainly just in the back. After I fall, I actually had some major back spasms that kind of I couldn't even. It was like I had the hiccups. I couldn't even carry on a full sentence without being interrupted by the spasm. Um, and then it was later on where it did actually start going down my legs to the point where my legs would just kind of give out periodically while I was walking or even trying to run. But they were always just focused solely on the back, trying to figure out what was going on with that.
First of all, thank you for your service. I'm sorry
Thank you.
this happened to you, trying to keep us all safe. But no good deed goes unpunished. So here we are. When you were having the legs give out, was it your legs were giving out because you were in so much pain that your body was just like, oh no, I'm done? Or was it you didn't necessarily feel pain, you felt a lack of power? Can you distinguish those, or is that ridiculous?
Yeah, it was more of a lack of power. Well, after I got out in 2019, they did find a torn labrum in my right hip,
Mm.
which they kind of characterized it as why I was kind of losing the strength and just kind of losing control of the leg every now and then. So they fixed that. I had surgery on December of 19 for my hip, and from there, the doctor's like, "Well, you're good. You have arthritis in the area, so you're still gonna hurt, but I haven't had any other issues with the leg since then,
Yeah,
minus the arthritis pain."
I believe that because a torn labrum is the when the hip rotates, when the ball rotates in the socket up to that point that um, it's going to hit the area where the labral tear is. Now this guy has had a joint replacement. Just ignore that. But the labrum is this area here. It's what holds the ball in the socket. And when the leg rotates in a way that happens to catch that tear, the pain is so severe it just drops you to your knees. So I'm guessing they were right about that, and that's what happened there. And we know they were right because when they fixed that, that went away, and hopefully it'll be many years before that arthritis in that hip catches up to you. That labral tear is often into the groin. Was yours into the groin or was it right down the leg?
It was just right down the leg.
Okay, interesting. Very interesting. All right, so that's gone, thank goodness. Bless that. And now let's move on and talk about the back. What are you feeling now? So that was the injury was 6 years ago, the labral tear repair was 3 years ago. Now we're 3 years later. What's happening with the back?
Same thing. Since the initial injury, it's almost excruciating pain sometimes, and I constantly have about a pain level about a 6 is my normal. It's just more of like a dull ache, stabbing kind of pain sometimes, and going through it, I think I've done like 6 different iterations of physical therapy for it. I've done injections. I've had an epidural injection. I've had Botox injection. I've had nerve blocks. I had just finished about a year's worth of pain management where they went in and did RFAs in the area about 6 different times total. Had minor relief briefly, but it just came back, and pain management was like, well, don't know why that's happening. There's nothing really else we can do for you. So
Now what, right?
yeah, exactly.
Well, at least they tried, you know?
Yeah.
Yeah.
From what my pain management was saying, they actually gave me the most knowledge of what was going on. So before then, it was like, oh, we don't know. I was diagnosed with degenerative disc disease, but from ever since then, they were like, oh no, your discs are fine. They don't see any bulging. There's no slip discs, no ruptured discs, nothing like that. From what my pain management doctor was saying, though, is that I do have pretty advanced arthritis in my lower back from the L5 to the S1 area, which he said that I don't really see this advancement until someone your age. Like, what happens? Like, oh, I fell off a cliff. Great, that would do it.
That would do it. Yeah.
Yeah. So
I want to
hopeful for the RFA, but it didn't work.
Yeah. Can I ask you a couple clarifying questions?
Yeah.
Did the RFA work even for a short time? Like, did it work for a few days or weeks or months, or it just never took? And you had a bunch of them. Did any of them?
Yeah.
Yeah.
I'd say the longest it actually worked was about a week.
During that week, were you pain-free?
Not fully, no. Definitely, it was a lot less, but not fully pain-free.
And I think it's a little bit dumb to put a number on it. But like, if I said it was 90% gone, that would mean it was almost all gone and I just felt a little bit of stiffness. If it was 50%, I'd be like, yeah, it was better, but I still hurt all the time. Were you like less than 50, more than 50% better during that week?
I was probably about 60 to 70% better.
Okay.
Like I had more mobility. I could stand longer. I could do things still with some discomfort, but not nearly as bad as it was, or it now is still.
I hope at the end of this, we come up with a plan that sees a light at the end of the tunnel that puts you pain-free. But let's say we don't. Let's say we got you to where you were during that week permanently. Is that good enough, or is that not gonna get you where you need to be?
I could live with about a 4 or 5 pain. After I initially got injured, I got to that point and I was able to do my job. I was able to actually re-enlist. Still felt it, but it was manageable. Still do things. But then it relapsed and just went downhill from there. So if I can get back to a 4 pain level daily, I'm good with that.
What kind of work do you do?
Currently, I am a security supervisor at a hospital.
And you, I worked at a hospital for most of my life. I bet you see a lot of crazy stuff like I did.
I see a lot of crazy stuff.
Yeah, it's an epicenter of zaniness in a hospital. What about your home life? I think I heard some kids in the background.
Yes, I have one little girl. She is 16 months old.
Oh, congratulations, brother. Good for you.
She definitely keeps us on our toes.
Yeah.
as you heard.
Yeah. Yeah. Is she the only one?
Yes.
Well, it's almost time for number two. Not that I'm telling you what to do or anything.
Sorry, all the nurses I work with say the same thing.
Yeah. It's a lot easier when there's someone else's kids to make to make recommendations.
Mhm.
I want to show you a couple things, if I may.
Yep.
So we talked about some stuff, and I want to put some images in your mind to it. And the first one was degenerative disc disease. So are you seeing my screen right now? See this arrow?
Yes, I am.
So this is a cross section through a human disc, and your disc has got two parts: this strong outer part, these rings. These guys are like fibrous rings, like Gore-Tex is made out of. It's even bullet can slow down a bullet because it's so many layers. Same thing here. This guy's really, really strong. This inner part is soft and smushy and can move. But that outer part can tear in this radial direction. And this is called an annular tear. And annular tears are things that go by a variety of names. Sometimes doctors call them, or biophysicists call them internal disc disruption. Doctors call them bulging discs or herniated discs, even though the nucleus is not, the soft part's not all the way, not all the way out. So they go by different names in different times, but for the most part, it's an annular tear. When you see those changes from once that annulus tears, first of all, you know something happened. And second of all, some force has gone through there, or it's just worn out slowly over time. But the other thing you know with some certainty is that there's an injury and there's a potential source of pain. So that's one thing, degenerative disc disease. Degenerative, and it's a little bit of a misnomer, right? You jump 20 feet and it's degenerative. No,
Yeah.
what that means is that that a lot of times we see an injury set up changes that accelerate degeneration. So for example, if you got one of those tears in that annulus when you fell in the Marine Corps, and then your body is now trying to heal it, trying to react, and over the years, and that's kind of what fits with what your story is, right? It hurt like heck. I was kind of good for a while, and now I'm having problems. It's sort of like I was injured. My body tried to fixate it and heal it up for me, but whatever that happened, it wasn't enough, and now I feel like I'm actually on the downside, getting worse. So historically, that's actually a pretty good fit with what's going on to you. And then I want to show you something else. Again, this is a different thing. You talked about having arthritis of the spine, and I want to blaze this image into your mind. You know, if your wife runs her fingers down the middle of your back, you have these bumps in your back. Or if you do that to somebody, you feel those bumps. That's this bone. This is called the spinous process. And if you were to kind of slide off that spinous process and come down to a flat bone called the lamina, and then you kept going, you'd get into a joint. And this joint is called a facet joint. And I always feel bad for the facets because they're like the least famous joints in the human body. Like everyone in the world could tell me that's the wrist joint or the elbow joint, but probably 1 in 1,000 people knows about the facet joints. But they're there and they're super important. Let me just grab a model so I can show you. Here's a guy facing you, and now I'm going to have him turn around, and he's hold on a second. I'm gonna come off this picture so we can make it a little bit bigger for everybody. So now this guy's facing me, and you can see the facet joints here and here and here. And they do what they look like they do. They're what allow you to bend backwards. They crush that way, and then bend forwards. They distract open. So very common to have, in a history like yours, very common to see an injury to a facet joint. And that injury then, it's kind of like ages you 50 years in one day. Now the body tries to heal it up, but there's damage to the cartilage, and every time you move, the damaged part damages another part, and it just kind of goes on and on and on. Yeah, arthritis is kind of the gift that keeps on giving. And that was what we saw in that picture, that joint, instead of being those smooth edges of the guy who right before he fell off the cliff, we've got these damaged and inflamed edges, which was probably the guy who came off the cliff. And so we've got these two options in your case. What is this pain? Is this an annular tear, degenerative disc disease type of pain, or is this facet arthritis? And the two things actually feel differently. So I want to ask you, and pain is pain for most of us guys, most everybody, right? But I want you to kind of like put it in your mind for a second and think about, is it more like an apple or more like an orange? And let's say the apple was, it's a knife in the back, it's there all the time, it's worse when I sit down. Sitting down actually makes it worse. You'd think getting the weight off would improve it, but it actually makes it worse. And it's not really off to one side very much. It's right in the middle, and it's there all the time and worse when I'm sitting. The other one, the orange, is it's off to the side of my back. It shoots down into my butt. It feels like it's coming from my hip. And this is hard for you because it was coming from your hip before, right? But it feels like it's coming from my hip. And then sometimes it even burns on my outer thigh. Now, can you describe your pain to me in those terms? Which one or both of those are you feeling?
I'm feeling both of them.
Okay, and that's a fair answer. So describe it to me. What does it feel like to you?
So recently, about 2 weeks ago, I actually threw my back out again, just trying to strap down my baby into her car seat. Simple motion, but that was definitely a knife in the back. I couldn't move. I could barely walk. Sitting hurt, laying down hurt, standing hurt. Everything hurt. I actually had to go to the ER for that.
Was that in the middle or off to the side?
That was in the middle.
In the middle, okay.
In the middle, yeah. I guess my normal pain. It's more off to the side. And I could feel it kind of burning in my hip. Feels like that's where it's coming from. Off to either the left or the right side. That's kind of my normal.
And your I hate to call pain normal, so maybe we'll call it your baseline. Is your baseline, your normal pain, is that's on the right?
It's more on the left.
It's more on the left. Okay, good to know. Good to know. Do you remember when you had that hip pain before you had surgery on your hip? Is this the same as that or different than that?
It's a little different. I feel it in the hip, but it's more like just above the hip joint.
Yeah. On the left.
Yeah, on the left. Whereas with when I had the labrum, I could actually feel it like right inside the hip.
Yeah.
And down the leg.
Yeah. And that's a really classical description of joint pain, low back facet joint pain. It feels like it's in your hip, but it's a little bit higher than your hip. Mm-hmm. And especially if you've had hip pain. I don't know why it is that way. Kind of the way we figured this out, weirdly enough, was there used to be, in the old days, doctors used to do injections into the facet joints. We don't do that anymore because, as it turns out, it destroys the facet joints, which is not what we're trying to do. Make things, we're trying to, and we're sworn to make things better, not worse. But bless our hearts, stuff happens. And so they, in those days, when the needle would go down, you would feel it pop into the joint. You would feel it go through the capsule and get into the facet joint. And the patients were awake during this, lying on their stomach on the exam table. The patient would say, "Ow, my hip." And we were kind of like, "What? What do you mean your hip?" "My hip. What are you doing to my hip?" It's so, I don't know, the brain just assigns that area internally to the hip. And just like a heart attack can feel for all the world like the pain's in your arm, but not one of us has our heart in our arm. It's the same thing. Like the pain is just a referred muscular pain for some unknown reason. Why the hip, we'll never know. All right, we got a couple of candidates. We got degenerative discs. kind of worried that you might have torn another one in that car seat incident, but we'll figure that out in a second. Then the second thing is the facet joint. I have to admit, going into this, I was leaning toward the facet joint because you did get a week of relief from the RFA. And RFA is not a treatment for degenerative disc disease. It's a treatment for facet pain.
Yeah.
So the fact that it temporarily worked, very common. RFA, 80% of people, 60% of people get relief of 80% of their pain for an average of 10 months. So 6 out of 10 people, that's not, that's good, better than nothing, that's for sure. But 60% of people get relief of 80%. That just means if your pain goes down, it goes from, in your case, 8 out of 10 to a 2 out of 10. And that relief lasts an average of 10 months. So in that 10-month average, there's a ton of people who, they get half the people get less than 10 months by definition. And quite frankly, there's a fair number of people who just get almost nothing, like you did, like a week. All right, let's have a look at your MRI. Drum roll, please. Hold on, I'm going to share. I haven't seen this either, so I'm excited to go over it. Let me make this bigger so we can see it. All right, this is you. And this is your MRI from before the most recent injury, before the baby injury, correct? Yeah, okay. So now in this MRI, this is the bottom of the curve of your back. This goes up toward your head and down toward your bum. If we go straight in from the back, we see these bones. Those are the squares. And here's your lumbar 5, 4, 3, 2, 1. And here's 12. And these bones are separated by discs. There's a disc, there's a disc, there's a disc, there's a disc. This disc is a beauty. She's practically perfect. See there's the gray disc, and then there's this dark line. The radiologists call that chemical shift artifact. It's not real. It's just an artifact that MRI does consistently because of the going from a soft to a bony compartment. But it's interesting, if you look at that along here, see how there's irregularity there? The chemical shift artifact is lost right there. And then if you go up here, you have preserved artifact, but this disc is irregular right there. And then this one, and then this one. So we've got multiple discs that are irregular. And this one right here, this is your L5S1. See how this disc ends, and then there's ligament, and then there's spinal canal? When this disc ends, see how it kind of cones up? This guy's getting ready to rip. I hope that's not what happened the other day in the car. Now we're going to go to this side. So this green line, if we were to cut you perpendicular, like I think they're having the last of the Halloween movies right now, or I forget who the guy with the saw was. So gross, but I don't know. Whoever, the guy who cut people right in half. If we cut you like that, you look here, and in this view, this is your lower lumbar, and this is a normal facet joint. This is where bone meets bone in a joint. And there's a little bit of joint tissue in there. But then as we go up, we start seeing this swollen, this white is swelling in this. And then here we've got swelling inside the joint on the left side, also a little bit on the right side, but more on the left with this evidence of old injury. And then as we go up further, these are normal. See how they're exactly the same. These are totally normal. And the shape of the facet joint starts to change as you get higher. Sometimes it's kind of a weird angle to look on for this, but if we look at this angle here, I want to see what the joint looks like. Oh, so this is a weird angle to look at, but this is the L5S1 joint right there. And this is the L45 joint right there. And what I see here is an injury that goes down into that joint. So that's your left L4-5. And I think that is likely your source of ongoing pain. Just looking at the rest. We always look at the foramina. These are the holes that the nerve roots come out of, and yours look good on the left. And now let me look at them on the right. These are just things that sometimes get missed. That looks good. Good all the way up. Yeah, so I think that's your issue, is you've got this left-sided facet arthropathy, facet injury, and that's likely the ongoing source of the pain. And then whatever happened the other day with the putting the baby car seat in could be a new injury to another disc or to the same disc. And it may just be, remember I showed you that annular tear, how it was almost through? What sometimes happens is you're doing something muscled up marine, you should be able to put a baby seat without injuring yourself. But if that thing is like one feather away from finishing the tear, then sometimes it's a routine movement. And it's funny because people will get into arguments. Well, he couldn't have injured his back stepping off a curb. I mean, that's ridiculous. Or he couldn't have bent over and picked up a paper clip and injured his back. But yeah, you can, because you couldn't injure yourself like that if you were healthy, if you were normal and didn't have this other experience. But if that thing was just about ready to go and it just went that final 1%, then yeah, a lot less force than you would think would be necessary can actually do the job. So I think you have probably most dominantly facet-mediated pain, and that facet-mediated pain is best treated by the treatment you've already had, which is radiofrequency ablation, which failed for you. And I hope that little nugget, I just heard her first. I hope that little nugget didn't injure it further, but if it did, it's not her fault, because it would have happened anyway. It just means it was about to go. So you got to get through your current period, and then we have to address the underlying pain that's making life hard for you. And I know you've been through RFA so many times, and I would not recommend repeating the RFA. The definition of insanity, some people say, is doing the same thing over and over and expecting a different result. So that, let's stop the insanity. But what is important to do is to confirm that the ongoing pain is coming from the L4-5 joint on the left. And the confirmation for that is the so-called medial branch block, which I assume you had from your pain management doctor. Yeah. When you did those medial branch blocks, you must have gotten good relief.
Mm-hmm.
And it just didn't last very long.
No, it didn't last long. Like I got the good relief. I actually got, because the VA requires 85% relief before they move forward with anything else. And I hit that for the full day that they were doing the test for the, I think, 12 hours that I have to map out. And I had the relief for about that long.
Which VA were you?
Like right off the bat.
Yeah. Which VA were you treated at?
Built to that.
Yeah.
I wasn't, so they outsourced me to another pain management center.
Okay.
They didn't have
it where you are. Yeah. Where do you live? Where are you?
Anchorage, Alaska.
In Anchorage. And were you treated in Anchorage or someplace else?
Yes, I was treated in Anchorage.
Okay. So basically at this point, I would recommend repeating the medial branch block to confirm the source of pain. I would not then go on to another RFA, because you've been there and done that. It's very likely to fail again. But if a second medial branch block confirmed the source of pain, then you've got two options. One option is endoscopic dorsal rhizotomy, a procedure we call DVR, direct visualized rhizotomy, where a surgeon puts an endoscope in there. The reason RFA doesn't work is that the little pain fiber that it's trying to buzz, it's not always where it's supposed to be. People are different. And when they go in there to do that needle ablation, they can't see where the nerve is. They just can see where the bone is. And okay, yeah, the nerve is supposed to be right there on this transverse process, but it isn't always. Sometimes it's over here. and sometimes it's over there. And if it's not where it's supposed to be, then you put the needle where it's supposed to be and you're going to miss it. And so that happens a lot, and that's probably what happened to you. Another possibility is that there's an injury to that facet joint and there's some micro movement. And so I would also recommend that you repeat the bending x-rays with flexion and extension, where you bend forward and backward. So you crunch forward and then you extend backward. And the way your back feels right now, there's no way you could do those, right? Because you're in an acute injury. So you got to let it settle down and then move on to that. If your flexion and extension x-rays were abnormal, or if you don't have the opportunity to get endoscopic visualized rhizotomy, and that's something we could apply for with the VA and see if they'll do that. But if those two things turn out to be negative, then the only other way to treat this is by fusion. That's putting in hardware to stabilize. We would say, look, this level is segmentally unstable, meaning it can't function. It's been injured in a way that it can't function without causing pain. And to fuse it, they would drop screws in through the pedicle bones at L4 and L5, connect them with rods, take out the joint, and that's it. That would freeze up that joint and end it. In my career, I was committed to doing this minimally invasively. So I would have actually recommended it only be done on the left side, the painful side. Most surgeons, I think, would recommend both sides. And I don't think either's right or either's wrong. It's just kind of different philosophies. But the goal would be to get you in the hands of a good surgeon and then see if they're willing to fuse that L4-5 for you. So that would be the next step. What are you thinking? What's your reaction to that?
I don't know. I'm good with either. Preferably not the fusion, but because I know a lot of people have had their backs fused, and sometimes it does well, sometimes it doesn't. So it is what it is. But
that's the truth. That is the truth. Well, and then I would, worse than that, right? The 17% of people who have a fusion go on to need another surgery at the adjacent level within 5 years. So you're a relatively young guy, young dad. You got to live with this a long time. So your risk of adjacent level issues is then significant. Are you taking any medications?
I've been prescribed meloxicam, which helps take the the high end edge off whenever I have that height. Yeah. Since my last injury, I've been prescribed straight ibuprofen and Tylenol, and I was given oxy, but I haven't really used.
Flush it down the toilet. Not only is it dangerous for you, it's super dangerous for that baby. You don't want that around that house. And it's just, I don't know why doctors are still doing that. It's just dangerous as hell, and it's not good for you. It's not good for anybody. So I would say.
Yeah, I didn't finish it. I was using it when it was really bad, but even then I could tell it wasn't really doing anything. So I just
get rid of it, dump it, get rid of it.
Yeah,
get rid of it.
Through it.
Yeah. Okay, and then a brace helps during the flare-ups, and a lumbar support orthosis, and there's no better brace place than the VA. Because of all the amputee issues, the VA has the best bracing services in the world that I'm aware of. So a lumbar support orthosis when it's flared up, moist heat, anti-inflammatories like Aleve or ibuprofen or meloxicam, along with them something to protect your stomach, because each one of them causes acid production that leads to ulcers. And just don't take them for more than a couple weeks. There is a bazillion complications of non-steroidal anti-inflammatory drugs, like in addition to ulcers, there's heart attack, stroke, kidney failure. I mean, nothing, 100% no-fly zones where you do not want to be. However, most of those problems really occur after a month. So if you can keep it to a week or two, it's fine. And then, we do advocate an anti-inflammatory diet. Why? If you can eat natural foods that make it better, you definitely want to do that. And it's not gonna eliminate the pain, but it can really take the edge off, just like taking a natural meloxicam. So all good recommendations. There's an end in sight for you. So the immediate treatment plan that I would recommend for you, if I were your doctor, is, which I'm not, I'm just some TV guy, but I can steer you in the right direction. But what I would recommend to you is get a flexion and extension X-rays, get a repeat medial branch block from that pain doctor just to see if that's still the source of pain. Get a repeat MRI to find out if that disc is ripped worse, because if it is, it changes the equation a little bit. And then come back and see me, and we could go over it again and figure out your next step if you're amenable to that.
Mm-hmm. I am.
All right. Getting cold up there?
Starting to.
Your days are getting shorter or getting longer?
Shorter.
Shorter. How much daylight you getting?
We're still getting pretty good. Like 12-ish hours.
Oh, good. Okay.
Around December, just before the solstice, we get a lot less.
Yeah.
Like 4 to 5 hours.
Yeah.
Of sunlight. But
yeah, I always say Alaska is like Colorado on steroids. It's just like, it's the real deal for frontier. So it's just a dream for Americans. All right, let's get those things, and we'll look forward to seeing you back.
Okay, sounds good. Thank you.
Love that baby for us. Bye now.
Bye.
Well, so interesting how it often comes back to kind of repeated themes here on Best Practice Live. But we've seen this movie before, right? Disc annular tear, degenerative disc disease pain, knife in the back, all of that stuff, versus, in this case, facet arthropathy, facet joint disease. The kicker here is normally facet arthropathy is caused by arthritis, which occurs because of trauma or osteo or inflammatory arthritis, rheumatoid arthritis, mostly in people over 55, comes on gradually, not associated with any specific injury. Nope, this is post-traumatic arthritis. This is a Marine who fell off a 20-foot cliff and hurt his back. Sadly, his back and his hip. I'm always, my heart goes out to people who get hurt doing the right thing, and boy, Josh is certainly one of those. I wish him well. I'm excited to see what his tests show, and we'll share his progress with you. I hope what we did digging through these two types of pain resonates with you and helps you find out and understand what's going on with your back. In any event, I'll look forward to seeing you back right here tomorrow on Best Practice Live. I'm Dr. Dan Lieberman. If you have a question you would like answered on Best Practice Live, there are 3 ways to ask. Leave a comment on any of our social channels, click the link to our website and complete the submission form, or call us at 602-256-2525. The more information you can give us, the better we can answer your question. So please contact us and we can walk you through uploading your imaging to a secure server. Please like and subscribe to our channel to stay up to date with information about your spine and joint health. Lastly, be sure to check out new episodes every weekday at 10 a.m. Pacific, 1 p.m. Eastern, where we answer all your questions.